I first was introduced to the UBM technology, it was like, wow. For the first time, we can fill an unmet need in accurately and quantitatively having the ability to measure the degrees of open or not of the anterior chamber angle of the eye. And this allows us to not only establish a baseline, but also to have a numerical value to monitor going forward for any progression and any further narrowing in the anterior chamber angle of the eye. I have found that by adding this diagnostic testing to my practice, it has improved the quality of care to my patients and enhanced my ability to make the right judgment call regarding the care and treatment for their anterior segment pathology. Mostly this has to do with narrow angle configuration and anatomical narrow angle. It has improved my ability far more than the subjective nature of a slit lamp examination or even performing gonioscopy. As I indicated when I first saw the technology, it was amazing to me as an unmet need in ophthalmology that the UBM technology actually provides us with a measurement, a quantifiable degree of opening or narrowness in the anterior chamber angle that allows you to make that call at the time as to whether some treatment is necessary, or it gives you the baseline and allows you to also numerically continue to monitor the progression of the narrow angle so that those patients who really need a procedure, a laser peripheral iridotomy, get it, and those people who do not need an LPI do not get an unnecessary procedure. I have had almost as many patients who I've determined based on a UBM that although clinically it appeared that their angles were dangerously narrow, with the advantage of really digging deep into the anatomy with the ultrasonic technology, it turns out that many of these patients would have undergone an unnecessary laser had I not had this technology. So it does allow me to be specific and to make the right call for the right reason on all my patients. It's my personal preference to perform the scans myself. It's just the way I like to run my practice. I'm more comfortable with it myself. I don't see why a trained technician couldn't be trained to perform the testing, but it's something that I have the ability in the flow of my clinic to have the time, and I like doing the test myself. I like having the control over it. I like not having to repeat, and this doesn't just apply to the UBM. If I don't like the quality of any diagnostic test that one of my technicians does, then I would just go back and repeat it, and I really don't want to do that with my diagnostic testing and make a patient go through that twice. So I just prefer to get the data myself, perform the test myself. I find, not just with the UBM, but with other diagnostic testing, that if I do the measurement myself, I tend to learn even more, and it helps me do a better job caring for my patients. So I prefer to do it myself, not that it couldn't be done by a technician. I have found many different types of patients that the UBM has come into play and served a great role, as I indicated previously, an unmet need as far as caring for and treating our patients with certain anterior segment issues. First of all, I can't imagine ever having to go back to not having the UBM available in my assessment of narrow angle and anatomical narrow angle patients. I've also had many patients, trauma patients, angle recessions, ciliary body cysts. I've had patients who have tube shunts for glaucoma and assessing the stability and the location and the anatomical configuration with the tube shunt. I've had patients with Marfan syndrome that I've been able to identify and show the dislocated natural lens of the eye in the Marfan's patient. Speaking of lens issues, placement of an intraocular lens, making, there's malpositioned lenses, finding out where you cannot visualize peripherally into where you have a patient and they come to you for another opinion, someone else did the surgery or your own surgery case, and you're trying to assess the stability of the intraocular lens. It seems malpositioned. You can see the tilt, you can see it's somewhat displaced, but you can't really see the haptics and where exactly in the far periphery where that lens is malpositioned and where the haptics are. But with the UBM, you can identify those issues as well. So angle recessions, malpositioned intraocular lenses. Obviously, the largest proportion of my patients clinically are my narrow angle patients that a determination has to be made as far as whether a laser procedure is indicated. But there are many other applications, and I keep learning more as I go. So in my day-to-day practice, while I'm evaluating my patients and I'm performing my anterior segment evaluation at the slit lamp, clearly the bulk of the patients that the next step would be a UBM is when I'm examining them, and I get the sense that there is an anatomically narrow angle, and it would be those patients that I would feel the next step is going to include a UBM. And I say include because most of my patients I will still go ahead and after making an assessment that the chamber angle appears narrow, I will still go ahead and perform gonioscopy, but there are many patients where gonioscopy is really difficult to perform. Patients with blepharospasm, patients who really find a gonioscopic evaluation unkind. We've talked previously in this session about patient discomfort undergoing the UBM. I have to tell you that in my experience, I have more patients that are uncomfortable with a gonio lens being applied than with the UBM technology. And that's not to say we should not perform gonioscopy. I perform gonioscopy all the time, but I like to verify my findings because there is a subjective element of interpretation even to a gonioscopic evaluation. And even though we all measure them and have our grades and apply our anatomical features to get a good sense, I have found for confirmation and sometimes further evaluation, the UBM is an invaluable tool. And again, so the steps would be a patient who has some kind of anterior segment issue, mostly a narrow angle, and the next step would be my gonioscopy, and my next step would be my UBM. And oftentimes, after I've performed my initial gonioscopy and corroborated the findings with a UBM, in subsequent visits, I have my patients say, Dr. B, can you just do that waterboarding test for me and not stick that damn lens on my eye? And I found that they find that not only preferable, but I find the data even better because, again, I can track and monitor the progress with a numerical value of how much the angle has changed. So nowadays, thanks to the UBM, I don't have to gonio my patients on subsequent visits. I rely on the UBM for that. So incorporating the UBM into the practice was not as difficult as I might have anticipated. I have previously mentioned that I thought there might be some resistance on the part of the patients. They might find it uncomfortable. I did not find that. I thought it would slow me down in my clinical practice, and I did not find that either. I have the luxury of having multiple exam rooms, and I work from room to room while the technicians help get the patient ready for the test, and it doesn't slow me down at all. In addition to that aspect of the clinical practice with the UBM, it was not a very steep learning curve, and I happen to have the Accutome device, and the Accutome people, their service, their support, their education, their in-servicing has been phenomenal. As far as integrating the UBM into any EMR system, much like other diagnostic testing, there are interfaces, and I'm not a computer person, but it is not a big learning curve or difficult to have the functionality for the diagnostic testing, including the UBM, have the appropriate interface in order to have the results be placed right into your EMR system. When I perform the UBM, it's been my personal preference to use the Immersion shell. I've had a lot of experience over the years and still perform Immersion A-scan, and that made the immersion aspect of the UBM very comfortable and very familiar with that in my hands. I did toy with the clear scan, and I just found in my hands I felt more comfortable with the immersion. There's no reason why it couldn't be done either way. They're both in clinical practice. They're both useful. Sometimes I feel that the immersion shell has an advantage because once the shell is placed on the eye, it's almost acting like a speculum and keeping the patients from squeezing and keeping them from being blepharospastic. And again, I find that to be an advantage of the shell. I feel like I have more control. I There is nothing inappropriate. There's no wrong answer. Whichever you feel you can get your best data in the most comfortable way for your patient, I would go either way. And in my hands, I feel very comfortable with the Immersion. I've been using the UBM in my practice since approximately 2012, so I've been doing it for the past 4 years. So in terms of obstacles to overcome when incorporating this or any other technology into a clinical practice, we spoke earlier about patient issues, potential issues with patient discomfort that I have not experienced in my practice. We talked about doctor issues as far as the flow in the clinic, and I have not experienced any disruption with that. But another necessary topic, which is realistic, is the economics of introducing any technology into the practice. And we all know in ophthalmology that there are diagnostic tools that are staggering. There are diagnostic tools that are more moderate in price. We also know that similarly, the reimbursement levels for some of what we do are not so good or relatively okay. So since one of the issues to overcome is not just adopting the technology, learning the technology, and the main priority for us as caring physicians is to do our best for our patients and have the patient care issue be the reason for why we do everything. We have to be able to afford to bring the technology into the practice. And I have found, especially compared with other technologies, that the pricing of the UBM device compared with other devices is relatively small, and the reimbursement with the diagnostic testing with the UBM is relatively decent. So if there is an economic issue, which we all have, in terms of being able to afford to bring the technology, this device is relatively within range compared to other devices, and the reimbursement levels are still pretty good in order to make it a win-win, primarily for the patient to do your best for your patient, and also for the practice to be able to economically survive bringing this technology into the practice. So for those of you who are where I was several years ago, thinking about it, hearing about it, it's the future of ophthalmology. It's the future of where we're going. Everything has become very much so incredibly reliant on imaging and imaging the anterior segment for these various pathologies. I think that don't make the mistake I did of waiting an extra year or two. If you're thinking about incorporating UBM into your practice, just do it. And the sooner you do it, the more grateful both you and your patients will be. So when it came time for me to evaluate whose UBM I might be interested in, it became my first stop that I checked with the Accutome people. The Accutome people have developed a terrific product here which fits right in line with their history, historically, of excellent, innovative products. I came to know Accutome through their Immersion A-scan technology. I've also utilized their B-scan technology, and when it came time for the UBM, I dare say that I'm not sure if I would have been able to go forward were it not for the innovation, the expertise, the support, and the training that Accutome has always provided me over the years with all of their devices, including this one. So I chose Accutome for that reason. I know there's plenty of other reputable companies, and I think that my take-home message would be, more importantly, as to which company you get a UBM from, is to just get one, because you'll increase the quality of care that you perform for your patients, and that's what this is all about. My preference, for the reasons I mentioned, I had a background of positive experience with Accutome. They stand by their products, they're innovative, they're supportive, and you can't make a mistake. I have not explored the other companies except for comparative reasons. But as I would much rather have anyone who's considering getting a UBM in their practice, more importantly, would be go ahead and do it rather than whose you get. because you will be doing yourself and your patients a favor, and that's what we're here for, is to do what's in the best interest of our patients.